Emma, I don't know if you've frozen. Before we started, Emma had some issues with her IT, so I think that might still be the case. I'm going to hand over to Michael to start with to update on the strategy, and then we'll take it from there.
Okay, okay, hi everybody. So I'm going to just talk a little bit about our strategy and then take some questions if anybody's got points they want to raise, and then we'll move on to collective action. So this is kind of a two-parter really, this meeting, and in some ways they overlap each other as well. So we'll talk about where that happens and what we're doing. So the aim of this really is that each month I come with often with James Hopkinson as our medical director. He's not here today, but we come and talk about what our strategy is, what our main areas of work are, um, and lately expanding on collective action. So it's really about transparency, and so the kind of activity we're in. So as you'll know, or you might know, and if you don't, you will in a minute. We've got a fairly new committee. So the committee started around May time for a 3-year term, and we set out between us using surveys with practices, but also talking among the new committee about what they felt were really important. And we said that our three main strategic aims we're reducing the work shift from other sectors, we're improving the financial stability of practices, and we're making the workplace a safer and a better place to work. So those were the three kind of main areas that we said we need to do more in. And that's in addition to your day-to-day support, to the practice forums, to all the other things that we get involved in. This is more of the, well, what's the big stuff you're trying to shift? And those are the three main areas. So and we're using resources, and I want to reassure people that we're not reappointing money from the practice levies. This is money that we have redirected from earnings through the LMC buying group that we head up, which is a UK-wide buying group with around 60 LMCs in it and 6,000 odd practices who save money through the buying group, and we use commissions from that to enable us to do more work for you in Nottinghamshire. So we're quite unique in that way. So I just wanted to talk about some of the work we're doing through the strategy and the main pillars of them. So I guess the first one, if I take the financial stability of practices, now this is ambitious. So obviously, what we're setting out to do isn't necessarily that we're going to be able to make all the practices really highly profitable. If we could do that, we would, of course. But what we're trying to do is work with practices and work with different products and services and ideas to help you incrementally to change your position, to improve your situation, and to better understand your finances. So one of the projects around that centers around locally commissioned services. And a good example, I guess, is the ESDS basket. So this is the one where you've got a number of services locally commissioned, all in one basket, and most practices are signed up to do it. Not quite everybody, it's not uniform across Nottinghamshire, but most are doing it. But what we did say a while ago now, 4 or 5 months ago, is that we would do some independent work to cost them up for you. And then we would use that data to come back to you as a profession to find out what you wanted to do with that data. Now, whether that be that you decided that you wanted to serve notice on the ESDS or you wanted to indicate to the ICB that you were willing to do that, that was the kind of discussion that we were going to have once we got this data. Some practices have already done this themselves and they've opted out of ESDS for a number of years because they felt that it didn't add up financially. Others have done it in the last year or so and are teetering on the brink of handing in the notice. And I imagine that the bulk of practices are kind of looking at this and thinking, well, we're not sure if it's really profitable, but we're actually quite dependent on locally commissioned services because our staff are paid using some of that money, and we're not sure what we'd do if we didn't have the income. So what we've done is we've commissioned, and the word commission, we've paid for independent accountants to come in with a range of practices to model this in their practices about what it costs them to deliver ESDS. It is difficult because it's a basket, so it's not as easy as just taking one or two services and negotiating a better price for those, which other areas have been able to do lately. But this is quite complex. It's a basket of services, but we are getting reports, hopefully by the end of September. It has gone on longer than we wanted it to, but it's taken a while for the accountants to get in there and do the work. But what we're hoping is that by the end of September, we can come back to you with data from practices, a range of different ones, different sizes, different characteristics, so that we can kind of draw some conclusions from it. But also, it would serve as some kind of guide as well that you can use in your practices when you are costing up services in the future, because it'll be quite nicely broken down into how the calculations were made and what different factors went into the costings. So that's what we want to get from that. As soon as we get the data out, we will look at sharing it, and we will share it anonymously in terms of, won't necessarily say the individual practices and all the different names, but we will certainly say the characteristics of them, where they are broadly, what kind of practice they are, and we will share the costings so that you can start using that for yourself. What we then want to do is, we will, in the spirit of what the GPC, the BMA are doing around balloting the profession, we'll do that in Nottinghamshire, and we'll do that around ESDS. And we'll ask you whether you're considering serving notice on the ESDS based on the data that we produce for you independently, based on other information that we'll make available to you, and also based on your own decision making. You know, what are you willing to do? Are you willing to serve notice on the ESDS? Because you understand more the costs involved. You've had an independent look at it, you've looked at your own figures, and you've decided that actually we might be better off not doing this. It's a really tricky one, and coming from a practice manager background from years ago, I fully appreciate that sometimes we do work that brings an income that isn't all that profitable, but it's income. And when you're cash starved as a business, it feels like you have to chase every penny. So I do get how this is difficult, but you know, you are businesses, you are contractors, you're contractors to the NHS for lots of different services, and we're trying to make sure that you're doing work that actually brings in the profits to pay you, and to make it worthwhile. So that's what will happen. We're hoping by the end of September that we've got these reports. We'll take them to you and ask you to consider your own position, and that will be really useful for us, because it'll give us, for the first time really, it will give us a really clear indication of how practices across Nottinghamshire are feeling about this. We get a lot of anecdotal feedback, we get a lot of pockets of information, but what we really need is an overall feel. And we're very happy to coordinate and to help you to coordinate kind of mass action around what you might want to do. It's still your decision, you're the contract holder, but sometimes knowing that others are doing the same thing is helpful, and that's where we'll be able to bring that to you, and make you aware of the strength of feeling on this one. ESDS is tricky, and the reason why it's tricky, apart from being a basket, is because we don't know what's going to happen next year. So in a sense, what we want to be able to do is make a decision by or in October, we want to be able to make decisions on what you want to do, and make that very clear to the ICB that this is your intention. But of course, what we don't know is what's going to happen next year. And my sense from some of the system meetings that I've gone to lately are that there may be a very flexible view of what comes out for local commission services next year. And the other thing we're trying to build on the side of this work, and on the side of our strategy work, is we're encouraging the formation of a GP collaborative body. And what that GP collaborative body could do, which is different to the LMC, is that it could act as a big provider across general practice. Now, we do negotiations, we do discussions and consultations around contracts for you and your practices, and we do a lot of interface work with the ICB over different contract matters. What we can't do is we can't pick up an enhanced service and deliver it ourselves or on your behalf, because we're not an entity that's a provider, but we're a representative body. But what a GP collaborative body could do, if it was set up that way, is it could almost be, you know, kind of quite powerful really to get involved in taking work from the commissioners, and working across the whole of Nottinghamshire as a block, and being able to talk at scale about what's needed in a very, very different way, and actually commit to delivering some of that. It's going to take design work. It's going to take a lot of discussions with the federations as well, because they're providers in their own right. It's going to take discussions of PCNs and practices. So we're hoping that in the next couple of months, we will have, at least in some sort of shadow form, a GP collaborative body. The other bit that the collaborative body should do is to form up really as a much stronger unit, in that interface across with secondary care and with community, etc., with the healthcare trusts, with the acutes, and all of those. And again, in a very different way, because there's lots of conversations going on around general practice, all in different parts of general practice. So you'll have conversations where a practice has had a chat with somebody in the ICB, or public health has spoken to somebody in a PCN, or the hospital has talked to somebody else in a different setting in a provider group. But actually having one solid block of the profession as a provider unit is the bit we don't have. We have a very, very fractured and splintered system in Nottinghamshire for general practice delivery, and very different to a lot of areas in that for most of Nottinghamshire, we have a blanket coverage of provider groups and federations, which a lot of areas just don't have that. So it's really interesting, but it's quite complex. But this is an effort to try and bring it all together and be an irresistible voice, so that when the commissioners are looking at doing things differently, that there is engagement all the way through general practice, all the way from the practice to the PCN up to federation level and at area level. And it's slightly different to what we do. So it's adding on to what the LMC does, but it could commit to deliver as well in a different way to what the LMC does. So that's work that's going on. We're encouraging it. We're trying to get some projects that we could get that would make people want to come and join up to this collaborative. But it all links into our strategy around that interface. We want to improve the interface. We're making gains on NUH over particular work in terms of some of the work shifts that comes across. We still need to know when it's not working right. And we're working with Doncaster and Bassetlaw, and we're working with Sherwood Forest, and we've got a lot more to do. So these are all in there. That's part of what we're trying to do, is what we would call our strategy. This is things we want to achieve. We want to measure them and show that we're improving. So the financial work, that's coming. I've told you about ESDS and where we're at with that. So we will come out to you as soon as we get those independent reports. And then we're going to ask you for what you want to do next. And we will help you with whatever those steps are. So that will be the next step with ESDS. Now, I'm going to bring Lucy in just to talk a little bit around the financial stability aspect of the strategy. So there is some really interesting work that you would have heard about last week, but I'm not going to presume knowledge that everybody was here. And it would be worth Lucy maybe just letting you in more really in terms of how we've come up with some of this work and what the outcomes are intended to be. So Lucy, if I just hand over to you just to talk a little bit around certainly the finance stroke kind of projects that you're involved in and how we're hopefully mopping up some of the money that is being lost to practices.
Thanks, Michael. Hi, everybody. So hopefully most of you will have received an email from me, and I also put a message on the Nottinghamshire LMC WhatsApp chat. And so an email went to all practice managers on Thursday last week, because it was the launch of our financial dashboard by the LMC. So following the results of the practice sustainability survey that we ran over the summer, obviously the results showed that quite a few practices are really struggling financially, and we see we know how much money is coming into global SERM, how much the enhanced services are worth, and we really recognise that we want to find a solution for you as best as we can. So I mentioned that our colleagues Steve Murdoch and Jason Gomez, we commissioned or paid for a piece of work for them to do to design a dashboard and a process to help you find potentially missed income on the 24-25 local enhanced services. So really it's just a reminder to have a look in your email inbox. EMIS practices, there's a slightly different way of working it. I mentioned in the WhatsApp that we had some issues with some people accessing the email because we're coming from a non-nhs.net email address. So if you're an EMIS practice, there is a workaround. We'll just send you a link, so let us know. But feedback that we've received so far is that it's really making a difference, and that it's finding uncoded, unclaimed work, which is exactly what we wanted it to do. So if you've got any questions or anything that you want to know more about with the LMC LES dashboard, please do ask. But I'd also refer you back to the e-update that we sent out last week, which has got a recording of the webinar that Steve and Jason delivered for us. There's the guides in there that have gone out, and also a PowerPoint presentation that explains it in more detail. And I'm just remembering as well, there's also a YouTube video that we can put in that explains it. But we're really proud of the work that we've done on financial stability, because we recognise how hard it is in terms of trying to claw back every penny. Michael, there's a question in the chat. I'll update in a second as well about some of the work that we're doing on reducing workload shift and safe working in the projects. But there's a message in the chat from Andy Summers, one of our committee members, that says, as part of the ongoing balanced discussion around ESDS, I wonder if practices need guidance around the costs of making people redundant, i.e. losing albeit a small amount of income by not doing ESDS. I'm going to bring you back in if that's okay, Michael, because obviously it is related to financial stability of practices.
Yeah, I mean, this is
because I was going to say I have an answer, but obviously we don't advise on HR sort of employment business decisions as a practice. But Michael, over to you for that one, please.
Yeah, we don't. I mean, there is some of this is very much in the public domain around, kind of statutory redundancy pay and the process you have to go through if you're going to make people redundant. So a lot of this is available to search up, and we can put that in a potted version to make it easier. But as Lucy says, you're always better off taking advice on your own situations. And obviously, in terms of employment rights, I mean, those you accrue at 2 years. But again, I'm moving into HR advice here. Once somebody's been there 2 years in your employment, then they gain employment rights before that point. That it might be slightly easier to move somebody out of the team if they've been there for less than 2 years, as long as there's no discriminatory factors involved. I mean, this is a tricky one. We hear a lot of practices say the exact same thing. We'd rather have the money, even though it's not really profitable, but it pays for our team, and we'd rather not make people redundant. And actually, even the cost from a morale point of view of making people redundant would outweigh the finances. So this isn't simple, and we're not pretending it is. I think what all we're trying to do really is deliver you data on what we're seeing independently, the costs of providing the SDS are in a few practices as best that we can. And it's to give you two things, as I said, it's to give you some kind of template approach so that when you then look at the next service that you're asked to provide, or you're thinking of providing, or even bidding for more proactively, that you've got the factors that the accountants have been using, that you can start doing that for yourself. There are some dashboards that people use in different areas for practices, things on Excel, etc., where you can put in your staff costs, you can put in your estates costs, etc., and put in the amount of money you're being offered. And it's quite rough and ready, but it just gets you a bit further down the line of costing things up. So we're just trying to help you with that aspect of it and just to understand it all. But the other part of it, as I said, is just so that, we always want more, but actually providing data to the commissioners is intended to be helpful for our cause to say, look, we've tested this with a few practices independently, so there's no bias. We just had the accountants come in outside. We've also had some practices cost it up themselves, and they're willing to share their workings. You can see this just isn't working for what practices want. And we need to just be honest across general practice. Just general practice as a group of contractors want to work at cost and not make a profit because it's better for their team and to keep the money. Or are we getting to the point, a bit like with the collective action, where people start being a bit more brutal about the business of general practice? And it's a very much practice level discussion to have. It's not even a PCN discussion, I would suggest. This is practice level. What are you willing to do? Do you understand what it's costing you to do the work? What else could you do if you weren't doing that work? And what's the cost of that? So we're encouraging that. We're just encouraging you to get into the right place so that you know about your financial situation. But what we want is we want the right money for you. We need to get to the point where the commissioners have to make a decision, and their decision is going to be one of a few things. So if a group of practices decide to serve notice on the SDS, then the commissioners can go, okay, we can find another way of providing that. Or they can go, look, actually, it's really hard to find that. That's not the right way forward. And we've had lots of data that's been provided to us. And if we can find a way of funding that better, then we'll do that. That's what we really want to get to. There are discussions going on over the coming weeks about this because there are other issues in here about who can provide some of these services, who can provide ESDS, if not the practices directly, who can hold those contracts. We're having a lot of conversations in the background about this because we want to make sure that the ultimate position is that you get paid fairly for your work. But as I said, I think that is this year. I also think we're in a really interesting place about where the commissioners might be looking for next year. But all of this is going to be really valuable because what it's going to get you into that headspace of, like with the collective action, is just being able to fully cost up and understand what it's costing you to do what you do. And then it gives us some leverage to go back to the commissioners and ask for the appropriate amounts of money for what you get and what you're doing. We can't all just say we need more because we'd always say that, and everybody across the ICS would say that they need more. But if we can evidence that what you're getting falls far short of what you need, then we'll be in a stronger position, and that's what we're doing.
Thanks.
So that's a long answer to Andy's question. I think we're happy to help practices who are going through this conundrum of what to do about their income and what to do if they free up work that they're currently paying people for. Maybe we should have those sorts of discussions if we ever get to that. But obviously redundancy is for most people a last resort.
Thanks, Michael. So just going back to practice financial sustainability and to answer Dr. Gowder's questions, he said, what's the difference between Sorry, I can't see the question. What's the difference really between the dashboard that we've built and comparing it to Arden's? So, Dr. Gowda, the brief that Steve and Jason was given was that I can use the templates and follow the guides. I'm going to refer you back to last week's e-update where Jason and Steve are talking in a lot more technical detail about the difference between their dashboards and the Ardens. But my understanding and the conversation that we have is that Ardens is for sort of the national specs, such as the DESAs, minor surgery, etc. Whereas the claims that the rules that they have built are based on the local Nottinghamshire enhanced services. But I'll put in the chat where you can fast forward the YouTube recording of them launching the dashboard and explaining it in more detail. And obviously it's also funded by the LMC, so I put that in there now. Khaled?
Yeah, yeah, like you say, the Ardens is on the national, but we can quite easily, and I could do it within 2 weeks, I'm the link for Midnots with Ardens, get them to do a localized dashboard.
Yes, so we've done that though.
Yeah.
Yeah, thanks, Khaled. Helen?
Can't see my camera working. There we go. Yeah, so Ardens do a local enhanced service for Nottinghamshire already. So we've got access to them. And actually, I've looked at the search. The Ardens ones just are a little bit more complex. Some of the, yeah, it's interesting comparing the two. And if you're using the Ardens templates, it doesn't necessarily follow through with the work that's being done locally.
Okay, thank you for that feedback. Thanks for that feedback. I'll pass that back on to Jason and Steve as well.
It's useful doing them both together, but definitely Ardens do write local services, local searches for the Nottinghamshire LES, and it does involve case finding as well.
Thank you. So just going back onto reducing the workload shift, yeah, I was going to say that as well. Obviously, not all practices have Ardens, as Umar said. So the feedback from practices that also don't use Ardens is at the dashboard. But I mean, any system that we've got in place that brings money back into general practice is a positive. Just thinking about the reducing the workload shift, and I won't go on this for too long, but in May this year, we obviously launched the GP consultant twinning scheme with NUH, and we're still continuing to push SFH and Notts Healthcare Trust to get going with their commitment to the GP consultant twinning scheme. But I wanted to share with you some feedback from consultants that have done this. So the idea with the GP consultant twinning scheme was to have 60 GPs and consultants across Nottingham and Nottinghamshire ICS to, you know, spend some time in each other's shoes and learn about the challenges in each other's environment and how they can work, how they can come together to put the patient at the centre and potentially work differently to help one another. So that launched in May for NUH, and the feedback that we've received so far is very positive. I'm going to share my screen and then just take a moment to have a look at some of the feedback from 2 consultants that we've received about what they found when they came to spend some time in general practice. Someone's just going to have to tell me if you can see that. Can you see my screen?
Yeah, we can, Lucy.
Yeah. So this is I've anonymized them, but this is some feedback from a GP consultant who's been in for general practice, so taken part in the GP consultant twinning scheme, spent 4 hours in general practice shadowing a clinic, and then the GP's reciprocated that visit and gone into secondary care. So you can see here that they're actually, you might be surprised to hear this, but they're talking, this consultant is saying about how they felt the IT systems are actually integrated very well and meeting the needs of the GPs that were working. They're saying here about how little information the GPs receive about patient hospital stays, and it would make a huge amount of sense if they were able to access some basic hospital systems. They've said a comment here about being impressed by the governance structures and how issues with patients could easily be flagged up for discussion. This consultant is saying that they actually have multiple clunky, poorly integrated systems in the hospital, which I actually find quite interesting because we're often talking about the IT that we have in general practice, perhaps not recognising or being aware that it's just as much of a problem as it is in secondary care. This consultant said that they found it really helpful. I've just highlighted this bit here. So we said to them, as part of doing the GP consultant twinning scheme, what will you take forward in your own piece of work? So this consultant said, I think we could work on the quality of our comms to the primary care, as well as being a bit more mindful of the asks we're making of them, which is obviously exactly what we wanted the GP consultant twinning scheme to do. This consultant as an action is going to say, going forward, to ask themselves, is there anything I could do for this patient which would decrease the workload of my colleagues in primary care, which I see as a positive result of the programme. Really recommended the programme and has sort of said that they think that we're on the right track, which is positive. And obviously the GP that took part in this project will have received £500 for participating. And then I will just show you this one as well, just briefly. So this is this is another consultant that's completed the visit and sharing about what they've done. So they said they found it enjoyable, the site that they went to, they learned about QOF and GP funding. Obviously I came from secondary care, as many of you will know, and I didn't have any understanding about how funding worked in general practice or the GP contractor model. And I would probably make a sweeping statement, but to say that lots of colleagues and consultants in secondary care still don't really understand how funding in general practice works and how the GP contractor and partnership model works. They see here about, they're talking about the IT system again, how the electronic GP's triage system worked. They've said here about the large volume of information that GPs have to process quickly. Secondary care clinicians should make clinical information, and rationale easy to spot. They should be specific as possible when providing instructions or actions. And if GPs are to request any unusual tests, then it's helpful to provide normal value or give guidance on how to action the next step. This was some feedback from the consultant actually to NUH about how they can manage their own email and internal communications between them, and this consultant is saying that they really recommend it. So stop sharing. We recognise that this project isn't going to change the world, and that interface is absolutely still going to be a huge key priority for us, and workload shift just continue to happen. But we know that behaviour change is a big factor in making a difference and making a change. So by having 60 GPs and consultants job sharing, there are interface champions really that will take actions away and do things differently. So I wanted to share that because I thought it was quite positive, and demonstrates another one of the projects that we're doing behind the scenes to reduce the workload shift into general practice. And then finally, just an update on safe working. So you will hear me talk more about this on the 23rd of September when we're launching our pathology automation project. But we've again been working with Kerry Salis, who's a GP, one of our directors of the LMC, and Stephen Jason, who have built a series of rules that we've been piloting with a handful of practices across Nottingham and Nottinghamshire, looking at pathology auto review for normal results. So the idea here is just to try and find ways and small changes that can make a big difference to general practice. So if we think about in the morning, when you log in before you've even seen patients, you often will have had to review 20, 30, 40 blood results at a time. The idea with this project is to try and make small changes to reduce workload and to make lives easier in general practice. So Monday the 23rd of September is our launch for the pathology automation and auto review project that will be available for System 1 practices across Nottingham and Nottinghamshire. And just a reminder for those of you that hopefully you do receive our updates. If not, please let us know. But we do put in a monthly You Said We Did, where we demonstrate the impact of the work that we're doing. But if you have any further questions for me or Stu or Michael, please ask.
Great, thank you, Lucy. Just to clarify, so I put something in the chat in terms of the dressing queries come from Dr. Butt. So we got confirmation from Rachel Harold at the ICB for those who are requiring specialist dressing. So it should not really be undertaken by practices. Appreciate there is a 13-week wait for the first appointment. So it'd be good to have further information about that, please, Dr. Butt, if where you're referring your patients to, and then I can look into that for mid-Knots practices.
Local leg dressing clinic.
which is at
I think it's Oak Tree Lane.
Okay, I'll look into that.
It's a patients waiting for their ulcers to deteriorate. Well, 13 weeks is a long time to wait.
Yeah, agreed.
Just going back to the chat, Stu, and back to ESDS, as we spoke about the dressings and the impact that has on practices and the leg ulcer clinic and the weights there. But this is really a conversation, I think, to have as a group. So Tricia Tudor House has said, I'd be interested to know from those practices who don't deliver ESDS, what impact it has on other areas. So, for example, where you need bloods for quaff, has quaff income gone down? Is anyone on the call that hasn't done ESDS be willing to share that, please? Helen? Thank you.
People, if you haven't done ESDS.
Yeah, so Tricia, I don't know if you're there and you want to ask a question directly to Helen, that's a therapy practice that opted not to do ESDS.
Yeah, happy to do that, Helen. So
Thanks.
it was just a thought that obviously if you don't do an ESDS, obviously you lose that income. That's fine. But there's the knock-on impact that if say you're inviting your diabetic patients and they need bloods doing as part of their quaff review, those patients presumably have to go somewhere else for those bloods. My thought is that a lot of our patients might be reluctant to go somewhere else to have those bloods done. So therefore, I'm not going to get the information that I need to do my quaff review. So is my quaff income going to go down as well?
Yeah, it is really complicated and it is far from ideal. And we have never done ESDS, and because we're in a health centre, that's the kind of history of it. And bloods were always done here in the building, the Mary Potter building, and it worked quite well. But since the contract has changed and patients have to go into town, it doesn't work as well. And that's why it's not simple opting out of ESDS. Historically, we have never done it. So it's a bit easier not to be doing it, but it's not simple. Patients have an initial multi-morbidity review, and then they're asked to go and get bloods, and that bit can fall down. Whereas if you could do the bloods at that initial multi-morbidity, it would be better.
Yeah. So I'm just thinking there's a number of other examples, like if a clinician wants to refer someone to the memory clinic, they need ECG and bloods, and it's hard enough sometimes getting them to come into the practice for those investigations, let alone saying, oh, okay, now you need to go to town for those. So
yeah,
it's obviously it's going to be really interesting to see the accountants' figures and what they've come up with from that report. But I think there are a lot of other bigger considerations as well. So yeah, interesting.
Ideally, you want it delivered in a big building like this, delivered on site, and that's what we used to have.
Thank you.
Thanks.
Thank you for that. Yeah.
Thank you. Back over to you, Michael, please. I think next section is the meetings about collective action and the work that we're doing behind the scenes with that.
Let's talk about collective action. So we wrote a little while ago with a menu of 10 options that the BMA had produced that was in this phase of collective action. They have got another one up their sleeve if this carries on and they don't get the sounds that they need from the government about the contract for next year. But we haven't seen that yet. So where we're at is that we've got these 10. I'm going to put them on the screen with a tracker. So Emma and the team have been really good in terms of putting this into a format whereby we can update you on resources, on template letters, on forms, on updated changes in terms of policy or anything that we're doing. So I'm going to share that with you in a minute, and we're going to send you this monthly so that you can see what we're doing. So this is a way of looking at those 10 menu items, seeing what we're doing, seeing what we advise and what we think is important for you to consider at your practice or PCN level. And on top of that, we're really happy to come out and meet you in PCNs, practices, patients. If you want to put us in front of your PPG or you want to kind of think of different ways of engaging them, then bring us into that if you'd like us to. Equally, use the open letter to patients that we produced a little while ago. These are all on our website. And that's really the point of the collective action, which is to put leverage into our hands to pressure the government, the new government, into funding core general practice. What we've seen so far is interesting in that there's this new R's allowance to bring in newly or recently qualified GPs. So that's interesting, and suspect that was done because that was a quick thing they could implement. What we don't know is this the government's way forward in that money they put forward for general practice comes in at collective level, i.e. PCN level, or was this just done because it was the quickest way to get some money out there and start to employ GPs? So I think that's the bit that we're really anxious about, that the BMA get the leverage to go back to the government and say, look, stop imposing contracts, stop putting all the money that you want to put into practices through PCNs. And this isn't an anti-PCN statement, but actually we need the global sum, we need core income to be higher. And then actually the rest of the system will improve as a result because you're funding practices properly. So that's what collective action is ultimately about. Now, I'm going to share the tracker. So we put this together. As I say, Emma and the team have put this together to keep on track of it, because there's 10 different items. And well, what can you use out of that? And how do you even start? You know, what discussions do you have in the practice? And how can we help you? So the point is that we're trying to make this easy to keep it in one place. And hopefully you can see on your screen a collective action tracker that the team have worked at.
Yeah.
You can, great. Okay, so number one on the possible actions was around limiting your daily patient contacts per clinician to a maximum of 25, and then diverting patients to local urgent care settings once the daily maximum has been reached. Now, we said that this is really about, you know, whatever you feel your limit is. It doesn't have to be 25, but the headline is 25 because that's what the European Medical Organization recommended. They can't believe how many contacts that general practice in the UK sees and feels it's unsafe. And so 25 doesn't seem odd to them. And when you take a step back and think about it, they're actually talking about 25 times 15-minute consultations, not talking about 10 minutes. So you're looking at just over 6 hours of appointment time or contact time, which doesn't have to be your daily kind of face-to-face appointment. It's patient care, direct patient care activity. Now, we don't think this should just be for collective action. This is one of those, it's not just for Christmas. This should be something that we do anyway in general practice, to recognize limits, to put in activity stoppers, if you like, to get to the point where you stop and you make new decisions about what you do because you've hit a point. Whereas what we're still seeing too much of is patients becoming the 70th one that the GP's dealt with that day, or the 75th or whatever. Not safe, burnout levels that we're reaching, all because you're bending over backwards to see the patients and see as many as you can. Now, that's a great thing to do, but we know it breaks you as well as it provides risks to the care that's being given. So we need to reset this. And the system is worried about this. They're worried about what happens if you do 25 and then you send everyone else to urgent care settings. And of course, you still need to make an assessment of needs. So even if you get to a point where you feel like you're getting to saturation point, you still need to assess the need of patients coming through and decide what to do with them, with your care navigation, with your triage protocols, etc. So you still need to have a way of ascertaining what people need. This isn't in isolation for me. This is something that you do alongside a much bigger project around your access and capacity. Some really good examples that we're looking to learn from, one in particular in Rushcliffe, that we can help to hopefully share in different parts of the area. For me, this isn't done in isolation, but in the spirit of the BMA collective action, it is. Move to 25, divert patients to other settings once you've reached that. So if we take it by the letter, that's what they're advising you to do as part of collective action. But as with everything, it is your choice what you do and how you do it. So, okay, so that's our view. So we think that greater use of other tools would help you to achieve it, but actually we should just do this as normal business. This isn't just for collective action. Updates. So we've got posters on safe working limits and assessment of needs to display in the waiting rooms. We've got the open letter to patients that I talked about earlier. So we've got more that we're trying to put together. We can also add now that the GPC have just released safe working guidance, which is quite a big document, and there's a summary document with it. We'll make sure you've seen that if you haven't seen it yet. But it's some useful stuff in there that you can reference, that you can use as a guide when you're looking at this in your own practices. And then there's the links to the files, so you don't have to go scrambling around for it all. This is all linked in to the tracker. So we want to build this up over the period of collective action so that you can see what we think, you can get updates on what's happening under each one, and any resources that would help you as well will be in this format as well. And as I say, we'll send this out every month. We're probably going to send you another one next week, because that's when we start moving to the BMA taking monthly updates from you and surveys from you. The BMA want to know from you what you're doing so that they can have a feel for how successful it is and what's going well and what themes are emerging. That won't be shared with your name on it. That's something that we're hoping locally that we'll be able to see so that we understand what's happening in Nottinghamshire. We won't know which practices, but hopefully we'll know what's going on if you fill this in. And it's not something we're going to hand over to the commissioners. This is something that will just help us to encourage you, to help you to know that you're not on your own doing this, and to learn from what's happening. So that's the number one. So you can go through this 1 to 10. Stop engaging with e-referral advice and guidance. So we've had a few questions about this. Please use the form. There's a template letter on here that you can use. And the reason you would use that would normally be, sorry, let's go back to that. The reason you would normally go for that would be, hang on a minute. Can you still see the collective action tracker?
We can still see you. Yeah.
Okay. So the reason you'd normally use that is if you were referring somebody for an opinion, well, referring somebody to be seen. I mean, let's be clear. You need to say that you need your patient to be seen by somebody. If you ask just for an opinion, or we need your advice or guidance or opinion, then any of those words can lead to them just saying, yeah, we'll send it through an A&G then. If you're saying, I want my patient to be seen, I've done this, I've done that, I've done this, I want them to be seen and consulted on by yourselves, somebody in your department, then you're not asking for advice and guidance. So we just need to be clear about what you're asking for. If it lends itself to A&G, you might get A&G back. But if you do get it back and you didn't want it, you can use that advice and guidance template letter, send it back to the hospital and say, actually, I still want them seen. I don't want advice and guidance. And you've got the right for that. You've got a right when you're referring your patient for further treatment and opinion. You've got the right for that, as opposed to just getting somebody writing you some support and advice. Some people love A&G and in its right place, it's great. So we're not saying bin it. We're just saying when you want to use it, brilliant. When you didn't want A&G and that's what you got back, use the template letter. And let us know. And if it becomes a pattern, let us know so that we can go back to the trusts and talk about it with them and tackle them. Because we don't feel that advice and guidance is the same as dealing with a referral. It's slightly different. Serve notice on any voluntary services undertaken. So that's almost, we're talking there about the expense to the practices. And are there things you're doing that you've done from a goodwill point of view for years, or you've done because it's filling a gap, because a service has stopped being commissioned and now it's falling back to you again? Well, we don't want you doing work that's not resourced. And we know it's hard to say no when your patient's in the middle, but we want you to have work that's properly commissioned and properly paid for. Inclisiran is an example. So we've heard in Midnots that practices have been asked to take on prescribing on Inclisiran and get involved in all of that. Well, you don't need to. It's not up to you. It's not supposed to be happening in general practice unless it's commissioned properly. And at the moment, it's not being commissioned. So we don't want to do work that isn't commissioned. It's also about safety as well. Stop rationing referrals, investigations, and admissions. So again, this is just where people are kind of putting barriers in the way for you to get people seen, So there's lots of referral forms. There's lots of things around kind of putting in like permissions for people to be seen for different things. Well, as far as we're concerned, if you put the referral in and it's on a perfectly well-written form, a referral form, then if you want to use the templates, great. If you don't want to do it, then it should still stand. And if a commissioner or secondary care has to make a decision on financing for a procedure, well, we're quite happy for them to make that decision and tell the patient. That's different from you being stopped from making referrals because of the cost. So it's up to the commissioners and working with secondary care on that one. If you made the referral because you think it's needed, you've made the referral and you think it's needed. It shouldn't be much more than that. Then it's up to the commissioners and secondary care to talk to the patients if they've turned down that procedure on a cost basis. You're not holding the keys or the funds for the commissioners. You're making a referral based on what you think is right for the patient. That's where it should start and end. Number 5 we've done. So we had this switch off the GP Connect update record functionality. So this was something that, if you remember, happened probably a month or two ago, a couple of months ago on the weekend, and loads of practices and PCNs got involved. What it did that was really important politically is it showed the government and NHS England that general practice can work collectively, it can get together, it can do things at scale, it can take action. And I'm not sure they're really used to that, because they assume that 7,000 odd independent businesses are going to be impossible to rally together. And what that showed is that actually there is strength in numbers and people are willing to do the right thing for their patients. So that was helpful, and it's helpful for paving the way for the BMA when they're saying that they need more for the contracts. With withdrawal permission, this is number 6 for data sharing agreements that exclusively use data for secondary purposes. So what we're saying there is if it's direct patient care, that's one thing. That's along the lines of the role. But there are other things used for performance. We've already written a template form that you can use if you want to withdraw permission for your data to be used for performance and other purposes. And that's been ready to go for a while. And we've talked to the people who would put in the change to that and actually withdraw the consent, and they're ready to do that. So, they accept that some of this information is not used for direct patient care, and you've got the right as the data controller to stop them accessing it. That's essentially what we're doing. This isn't to be belligerent. This is to take control. Free signing up to new data sharing agreements or local system data sharing platforms. So that, again, that's up to you. And as they come through, we'll list them and we'll advise you as we go. But we're just basically saying you're in control. Switch off medicines optimization software embedded by the local ICB for financial savings or rationing, i.e. not really about the clinical benefit for patients. This is about cost saving. So number 8 there, this is up to you. We know that this is one of the ones that a lot of the people in the system are not happy about. Things like script switch and other technology, because it's a way of moving away from maybe some of the branded medicines and paying more as a system than some of the generics and other switches that can happen. You don't have to engage with that. You might feel like you have to because you get a league table that says about your prescribing spend, but that's not contractual. This is about you doing what's right for you and your patients. If you want to use that software and it's helpful for reminders, great. If you don't want to use it, you don't have to use it. Turn it off. Number 9 is defer signings of declarations of competence for all these things. So these are things that the GPC, NHS England are sending down at the moment. But we will advise you when there's a change to that. So the cloud-based telephony sign up for September, well, GPC say you do need to sign that because that's actually around your contract. But there are other data sharing agreements that come through and declarations that are for performance. It's not about your contract. It's just because the commissioners want to keep a close eye on you. So when they come through and you're not sure, let us know and we'll tell you a blanket piece of advice. It's then up to you if you want to follow that. And 10 was about any decisions to accept local or national pilot programs that we're advising, that the BMA are advising not to engage with. That's not so much here in Nottinghamshire, but there are areas where there's money going into pilot schemes across PCNs to work or at neighbourhood level, but in a bigger footprint and do things quite differently. And there's money priming them to do that. Well, GPC is saying, great, if you do all of that, you're just kind of furthering the cause for putting money in at the level that is keeping it away from the practices. So, there's a feeling there that we need to feed the practices from a core contract person point of view. And then we can build up the collaborative working. Then you've got strong general practice that you can build up collaboratively. And where it makes sense to work together and do things at scale across the neighbourhood, great, well done. What we're worried about is that we're putting so much now into collaborative working, but we're neglecting the practices who are the people who are the collaborative workers. So that's what we need to change. So these are the 10. As I said, what we'll do is we'll keep this updated. Any resources we'll put in the file section. We'll put these on our website so you can find them there under collective action. And if you have any issues around this, or you have discussions that you want our help with PCNs, with colleagues, with patients, with MPs, then just let us know and we'll get involved with it. So I think that's all I wanted to say on that. But it's quiet at the moment. If people are wondering what's going on, it feels quite quiet. We've all had the holiday season. There's lots of people been away that haven't then been able to talk about it in their practice teams. So I think it's going to start ramping up in September. And if it's helpful to talk about what you're doing and to compare with other people, then use us as conduit to come out and talk to you and to tell you what we know from other practices, so that, you know, we can kind of encourage you that you're not on your own. I think a lot of people are worried that this is going to be exposing for them if they do it. Well, we know that this is happening across the country. And we've had questions. There's this WhatsApp group that hopefully a lot of people are on, which has got over 400 people on it now, Nottinghamshire WhatsApp group for general practice that we're the admins for. And there are questions on there about things like, you know, should we all do the same thing together at the same time and coordinate it? And we've always resisted that, and the BMA have resisted it, because actually it's a lot more effective for you to do things in your own time the way you want to, that suits you in your practice. But it also makes it a lot less predictable for the commissioners to kind of stop or stifle, and therefore it gives us a much better hand to give back to the BMA when they're talking to the government. So if anybody wants to join, we can obviously let you know how to do that and get you links to do it, to join the group. As I said, there's over 400 people on that WhatsApp now. It's intended to be there to update you on what's happening nationally, but there is an option for us to engage through that as well. But if you've got queries directly that are for the LMC, we'd advise you to email the liaison inbox for those. But do engage through the WhatsApp. That's a really useful way for us to disseminate information and talk about some of this collective action that we're involved in. So I'm going to stop talking and just be on receive mode, really, if anybody wants to ask questions or talk about how they're finding things.
Hi, Michael. Thank you very much. There's a question from Dr. Butt in the chat. Please comment on prior approval forms. If we do not do them, there is a lot of toing and froing as secondary care just refuses to give patients appointments unless referrals are accompanied with these forms.
We're in discussions with them at the moment. You're quite right. And we know that this is the case for a lot of forms and templates, that they're just going to get pushed back to the practice. So we keep pushing this now with the Secretary of Care and with the commissioners to say, look, they've got the right to get this through. You know, you can keep doing this, but the practices have the right to get these referrals through. It's up to you to do what you need to do at your end. But a referral is a referral. So there's work to do on it. This is happening in the background, Khalid and colleagues. And the committee, we're going to talk about it tomorrow night with the LMC committee with our GPs about this. But we're going to get resistance because it's a big change. And a lot of people are so entrenched in their positions that they think that's the only way. We need to, as a group, say collectively, we're not doing your forms. We're not engaging with this nonsense. We're doing a referral because we think it's right for the patient. You go and do what you need to do and tell the patient what you've decided, if that's not to see them. So we keep pushing that, and that, you know, we'll let you know more as that progresses. But we're trying to. This all came out, I think it was the 1st of August, and there's a lot of work on the back of it locally to try and get our local secondary care and tertiary care, etc., to take it seriously and to understand what they're meant to do. And as Lucy said earlier around the twinning scheme, there's a lot of ignorance actually of how this works, because this is just how they've known everything to be for a long time.
Excellent, thank you very much. Also in the chat as well, so Emma behind the scenes has just put in our template documents on collective action, which you'll find on our LMC website for you to use. Also on there will be the tracker that's Michael's gone through today, so you'll be able to see our actions as we go along in terms of collective action. And there's also the letter as well to GP colleagues that we wrote on the 1st of August. That may be worth taking a look if you have not seen that. Conscious of time, are there any more questions for Michael or Lucy or the liaison team? Oh, stunned silence. Okay. Right, conscious time, we'll begin to wrap up the session. So thank you very much for joining today. Next week, we will be joined by Michelle Canning from Capstix, who'll give us an update about premises, which will be pretty useful to those who are in partnerships as we go forward. So that concludes today's session on Monday, the 9th of September. We'll have a lovely week, stay safe, and we'll hopefully see you all next Monday.
Thanks, all. Bye.